This is Thomas. He is an 18-year-old male and has left school this year. He currently doesn't have a job and is couch surfing with his girlfriend, Sharon, in Melbourne. Thomas was first diagnosed with diabetes type 1 last year. Tom's girlfriend has brought him into the emergency department after he began to have shallow breathing and began to vomit. He first began to feel a bit sick a couple of days ago, according to his girlfriend, but has gradually become worse. Over the past days, he has been urinating more frequently and complains about a headache. He has been vomiting since this morning and it hasn't let up. Further cause for concern is Tom's temperature, which is 29 degrees and rising. On closer inspection, it can be found that he is becoming tachycardic, with his heart rate of 109 beats per minute. Other clinical tests indicate Thomas's blood sugar is 35 millimoles per litre. He also has high potassium levels and dehydration. Further contributing to his ill health is a foot ulcer located on his right ankle. This has been dressed poorly and will have to be done again. Insulin is vital to the way we produce energy. Insulin is located in the extracellular matrix, where it binds to glucose to enable glucose to enter the cell and undergo glycolysis, producing ATP. However, without insulin, glucose is unable to enter the cell. With nothing else to burn, the body is forced to burn fats, which produce ketones, causing ketoacidosis.
Hyperglycemia is an underlying cause of diabetic ketoacidosis. It often occurs in type 1 diabetes patients due to their inability to effectively secrete insulin and circulate to the body's cells. As there are limited insulin production or defective insulin present in the body, it cannot trigger target cells to uptake glucose that, upon glucose level testing, would present abnormally high in diabetic patients. Furthermore, hyperglycemia weakens leukocyte effect, which can affect Thomas as he has a venous ulcer, which would increase risk of infection and increase wound healing time. Specifically, the most common predisposing factors in the progression of hyperglycemia is the inadequate use of insulin therapy, which, if not attended to, can lead to the development of diabetic ketoacidosis. In order to restore levels of blood glucose, management through coordinating electrolyte imbalance and insulin therapy is critical. Electrolyte imbalance, specifically potassium, is evident in diabetic ketoacidosis. Low blood pH and blood glucose levels trigger potassium to move out of cells into blood circulation. This process increases potassium levels, however total body potassium levels are lowered due to osmotic diuresis. Potassium is also excreted via urine in patients that have diabetes as their kidneys have reduced capacity. An increase in potassium levels in the blood ultimately leads to hypokalemia, which can be detrimental to the heart as it needs adequate levels of potassium for normal functioning. Therefore, it is vital that electrolyte imbalances are replenished with electrolyte supplements to reverse acidosis. The effects of hyperglycemia causes dehydration. Cells become dehydrated and imbalance electrolyte levels because potassium moves from the intracellular to the extracellular fluid, leading to hypokalemia. Furthermore, dehydration in patients with diabetic ketoacidosis is caused by increased urine output. As the body is trying to balance sugar levels in the blood, the kidneys cannot retain extra sugar, and therefore glucose is excreted via urine. Additionally, patients become dehydrated due to the decrease in pH. This increase in acidity can cause patients to vomit. The increase in pH occurs due to the rapid accumulation of ketones being produced as the body has to break down fats for energy because they cannot utilize glucose. Dehydration also causes tachycardia, which is why Thomas may be presenting these symptoms. Specific management goals for Thomas who presents with diabetic ketoacidosis are fluid recovery, reversal of acidosis and ketosis, reduce blood glucose levels to norm, replacement of electrolyte imbalances, deciphering Thomas's reason for obtaining diabetic ketoacidosis, educate Thomas about diabetic ketoacidosis and why it happened and how to prevent it in the future. And some pharmacotherapy goals are the regular provision and monitoring of insulin to correct his hyperglycemia, provision and monitoring of electrolytes such as potassium, and education regarding his medications, such as the advantages for recovery and why they are important.
Therapy number 1, insulin therapy. Generally for patients with diabetic ketoacidosis, insulin is administered intravenously with a fixed rate of 0.1 units per kilogram per hour for adults. The introduction of insulin is required to reduce ketogenesis and blood glucose as it assists in correcting any imbalances of electrolytes. Ketogenesis is all about the body starting to break down fats instead of carbohydrates to use as energy, as there is an insufficient amount of carbohydrates in the body. Despite Thomas being overweight, ketogenesis could be a problem for him as he is homeless and therefore would not be eating nutritious foods and would still lack sufficient carbohydrates. Also, due to Thomas having type 1 diabetes, his body cannot produce insulin, hence why he is hyperglycemic, and therefore requires insulin to decrease any glucose being produced by liver cells and to decrease his blood glucose. For Thomas, his insulin therapy isn't only important for his diabetic ketoacidosis, it is also a great help for his venous ulcer. Patients presenting with the venous ulcer as well as diabetes, such as Thomas, have a slim chance of their venous ulcer healing quickly. This is due to the hyperglycemia in the peripheral arteries, which causes the endothelial cells to not function properly from the lack of glucose available to them. Dysfunctional endothelial cells cause a decrease in vasodilators, which constricts blood vessels, which leads to a lack of blood reaching the ulcer. This is why it is so important for cells to be able to uptake glucose, as without this function, a variety of problems follow, hence why the insulin therapy for Thomas is of the utmost importance. Therapy 2, rehydration. Patients with diabetic ketoacidosis can generally become very dehydrated, hence why they require around 6 to 9 liters of fluid replenishments. The reason behind rehydrating the patient is so their electrolytes may be restored and to help increase the volume of blood that is circulating around the body. Due to Thomas's dehydration, it would cause his blood viscosity to heighten and make it harder for his heart to pump blood around his body, which would only increase his hypertension. In order to make sure this doesn't happen, rehydrating him would allow his blood to become less viscous, which allows the heart to pump his blood more easily, and therefore it reduces his high blood pressure and tachycardia. Therapy 3, potassium repletion. Lastly, the final major aspect that needs to be tended to is the potassium levels of the patient. As diabetic ketoacidosis causes potassium levels to decrease, patients must be replenished, as allowing potassium levels to become too high or too low can be life-threatening. Thomas's potassium levels must be closely monitored as he is undergoing insulin therapy as well, and this has a tendency to lower the potassium levels in his body. The low levels of potassium are caused by osmotic diuresis, which is defined as the kidney's inability to reabsorb water. Therefore, the excess water is eliminated from the body via excretion, hence why Thomas is experiencing such frequent urination. Additionally, with his kidneys not being able to absorb water, this only contributes to his dehydration. So in order to stabilize his potassium levels and to also aid with his dehydration, he must be administered potassium, and he may be given normal saline to encourage normal kidney function, where there is a regular exchange of water and potassium. Despite insulin therapy, hydration, and potassium repletion being the main three and most vital forms of management when it comes to patients with diabetic ketoacidosis, there are still other, more general management strategies that can be put into place, such as vital signs. Vital signs serve as a baseline for a patient's treatment, and it allows nurses to detect if the patient is getting better or if they are deteriorating. For example, taking Thomas's heart rate as a part of vital signs at regular intervals allows nurses to know if hydration therapy is working properly. Other management strategies such as blood tests can be done to check if his blood glucose levels are steady. Little strategies like this can be used to ensure that Thomas is on the right path to recovery. In accordance with the National Safety and Quality Health Service, NSQHS, the standard most relevant for Thomas's case is Standard 9, which is recognizing and responding to clinical deterioration in acute health care. Considering that Thomas is undergoing therapies that have a tendency to cause his body to go through major changes and to fluctuate, it's important for a nurse to be able to recognize and respond to these changes promptly. In being able to respond to these situations quickly, it improves the quality of his health care that is delivered, and it promotes proper safety for Thomas. Not only does it prevent any other serious complications from occurring, it reduces the complexity of the care that would have needed to be delivered if the patient's condition did happen to deteriorate. In order for proper detection to take place, it is completely up to the hospital to have standards and protocols that are strictly followed if and when patient's deterioration is identified. According to Noble, Bell and Cox, taking care of a patient presenting with diabetic ketoacidosis is the job of all nurses. This means all nurses involved with Thomas's recovery have a role in optimizing his well-being. This requires undertaking tasks such as 1. Monitoring the fluid that he is being prescribed to assess for any arising complications and to make sure he isn't being prescribed too many fluids. This also includes monitoring his fluid output and keeping a very comprehensive fluid balance chart. 2. Administering his insulin at prescribed levels and increasing or decreasing these levels if need be. 3. Making sure Thomas's potassium levels do not drop too rapidly after receiving his insulin therapy. 4. Keeping him involved with his therapies by gaining his consent and explaining to him what he will undergo and what is expected of him. In doing this, it places him in an environment that is relaxed and allows him to gain the nurse's trust. And 5. Giving him the sufficient support that he needs, such as diabetic specialists, to educate him on his situation. In educating him, it will give him an understanding of what he must do and change within his lifestyle so that he may better his health and well-being.
Hi, my name is Acelia and I'll be focusing on the relevant pharmacological interventions for our patient. The primary treatment goals will be to lower hyperglycemia and ketoacidosis, address our patient's hypertension, and treat any infection in the diabetic foot ulcer. The first pharmacological intervention I'll be focusing on is administration of short-acting insulin. Short-acting insulin, in particular, is used in patients with diabetic ketoacidosis due to its rapid onset and short duration, and is ideally commenced alongside intravenous fluid replacement. Both type 1 and type 2 diabetes are indications for the administration of insulin. However, in patients with type 2 diabetes, insulin is only used in cases where it is inadequately controlled by diet, exercise, oral medications, and in cases where anti-diabetic medications cannot be used, such as during pregnancy or after surgery. Insulin works by promoting cellular glucose uptake and thus restoring the body's ability to metabolize glucose. Further actions of insulin include inhibiting endogenous glucose output and lipolysis. It is important to remember that both hyperglycemia and thiazolidinones, which is a group of medication used in the treatment of type 2 diabetes, are both contraindications for actrapid insulin. According to the Australian Medical Handbook 2017, the side effects for actrapid insulin are hyperglycemia, weight gain, allergic reactions, local reactions such as arrhythmia, itching, lipodystrophy, and lipoatrophy. The safety and monitoring considerations that should be undertaken include consistently evaluating patients' blood glucose levels and being aware of possible renal or hepatic impairment, ensuring the patient consumes a carbohydrate-containing meal within 30 minutes of administration, and educating the patient on their condition and notifying them that alcohol may increase or decrease hypoglycemic effect, monitoring closely in pregnant and breastfeeding women, and considering the possibility of insulin resistance if treatment is not effective. The fourth pharmacological intervention I'll be discussing is flucloxacillin, which is used to treat infection caused by bacteria. Indications for this medication include staphylococcal skin infections, pneumonia, osteomyelitis, septic arthritis, septicemia as an empirical treatment for endocarditis, and surgical prophylaxis. Flucloxacillin is a bactericidal that works by binding to penicillin-binding proteins and thereby interfering with the bacterial cell wall, eventually resulting in bacterial cell death. It is important for nurses to know that cholestatic hepatitis and hypersensitivity to penicillin are both contraindications for flucloxacillin administration. According to the Australian Medical Handbook, a temporary increase in liver enzymes and bilirubin are a common side effect of this medication. Cholestatic hepatitis can also be a side effect, however, this is extremely rare. It is imperative that nurses ensure that the patient does not have any allergy to penicillin prior to administration of this medication. The third pharmacological intervention I'll be discussing is atenolol, which can be used to treat Thomas's tachycardia. For the use of atenolol include hypertension, angina, tachyarrhythmia, myocardial infarction, and chronic systolic heart failure. Beta blockers like atenolol work by reducing heart rate, blood pressure, and cardiac contractility. Beta blockers depress the sinus node rate, slow conduction through the atrioventricular nodes, and prolong atrial refractory periods. This is done by blocking beta receptors in the heart, peripheral vasculature, bronchi, pancreas, uterus, kidney, brain, and liver. According to the Australian Medical Handbook, there are several contraindications for the use of atenolol. This includes bradycardia, a second or third degree atrioventricular block, sick sinus syndrome in patients without a pacemaker, uncontrolled heart failure, peripheral arterial disease, Raynaud's phenomenon, shock which can be either cardiogenic or hypovolemic, and severe or poorly controlled asthma, as beta blockers can precipitate bronchospasm. The side effects for atenolol can include bradycardia, hypertension, orthostatic hypertension, nausea, diarrhea, bronchospasm, dyspnea, cold extremities, exacerbation of Raynaud's phenomenon, fatigue, dizziness, abnormal vision, alteration of glucose, and lipid metabolism. The 2017 Australian Medical Handbook suggests that in patients with increased risk of bradycardia and hypertension during surgery, the medication should be continued throughout the procedure. It is also suggested that in elderly patients should start off with a lower dose, and administration of atenolol in pregnant or breastfeeding women should be avoided due to the association with intrauterine fetal growth retardation and possibility of the medication passing into breast milk. This concludes the pharmacological intervention section.
Using all the therapies and interventions appropriately, and allowing Tom to provide feedback to allow them to be refined, he should be returning to full health as quickly as possible. Thanks for watching.